Thank you, ma'am, for this kind words. Thank you, Banshi sir. Thank you, entire organizing team of Diabetes India for this opportunity. Thank you, the DGenius team and all my teachers here. My interesting topic will start off with common yet underrated challenges in daily diabetes therapy. This would be my flow of talk. We all know that management of diabetes in India is definitely a unique and a complex challenge, not only just because of the high numbers, mainly because of the diversity in people we come across, as well as across the states, and also the varied dietary and cultural practices across the places. The glycemic control is suboptimal. We all have the various classes of drugs in our purview, but yet almost 70% of the people, the target A1C is still not reached. And we know the numbers. This is a slide which is going to come across over the next 3 to 4 days. I think that this one and the next slide. This is a landmark ICMR INDIAB study done by, proud to be from this institute, from sir and ma'am. Almost 101 million people with diabetes, 136 million people with pre-diabetes. And apart from this, what is important is the other comorbidities like your hypertension, dyslipidemia, ultimately puts you at a higher risk of cardiovascular diseases. What is important when you talk about the challenges in therapy? I think this is something which is very important in our Asian Indian phenotype. Apart from the genetic susceptibility, mainly we have this low birth weight. At a low normal BMI, we tend to have a higher insulin resistance. And just it's not about insulin resistance. Even along with insulin resistance, though you have a phase of hyperinsulinemia, there is beta cell exhaustion and your insulin secretory defect. These ultimately puts you at a higher risk of progression of diabetes, increased inflammatory markers, increased cardiovascular risk. Even in terms of the treatment, definitely these aspects we need to keep in mind when you are treating when compared to some other ethnic races. And when it comes to management, the commonly prescribed is obviously the diet and exercise, but we all know that definitely when it comes to compliance with diet exercise, it generally remains on paper. Probably the enthusiasm is quite good when people start off with newly detected diabetes or during the gestational diabetes, but generally the adherence to diet and exercise is suboptimal in our people. This is a challenge when you see somebody in the clinic or in your setting. The challenge is how do you approach a case? How do you balance both your precision as well as your individualized care? These are some of the things which we keep in our mind when you treat somebody. This is what I was talking about the rapid progression. So you're getting somebody with, in Indians, you can see that pre-diabetes generally progresses. The progression is slightly quicker as compared to some of the other ethnic races. Even at a lower BMI, probably you compare Paima Indians with Indians, our BMI is much lower. And even the presentation of pre-diabetes is different in our population. Generally, we know that IGT and combined IGT, IFG, they respond to diet and exercise, whereas the isolated IFG is one thing which is quite high in our population. And again, they kind of don't respond to your diet and dietary interventions. So it's very important that when you get somebody with pre-diabetes, you need to recognize this fact and you need to decide when to be aggressive, when to think of pharmacotherapy, and when to probably carry on with diet and exercise. And even those who are detected with diabetes, almost 70 to 80% of your beta cell function comes down. So it's very important you hit early, hit hard. And even when you think about combination therapies, I think much before the verified trial, we have been practicing. We have used generally a combination of either a metformin, sulfonylurea, or a metformin or a gliptins. And we know that those therapies which actually protect your beta cell function plays a very important role in our population. This is something which we need to keep in our mind when you manage diabetes. This is the clustering of type 2. This is very specific for our Asian Indians. What is two important subtype is the thyroid subtype as well as the SERD subtype, the combined insulin resistant and deficient subtype. Why do you want to know about these subtypes? Because when you plan therapies, each one responds differently, and when you have a background of clustering, you tend to use the agents accordingly, and also you can screen for complications. Probably as you are treating a severe insulin deficient subtype, you need to think of using an early usage of insulin or those therapies which will help in your insulin secretion or protect your beta cell function. Probably you are treating somebody with SERD, you need to be more aggressive with multiple therapies. These are some things which you need to keep in our mind. And it's a very common challenge when you see our patients tend to ask, doctor, my relative is being treated with just one drug. You have been put me on almost 2 to 3 medicines plus insulin. Why my sugars are not under control? Probably a mild diabetes may do well with just a metformin there. And insulin resist, the concept of diabetes remission may be much better for somebody with an insulin resistant obese type 2, where healthy weight loss can achieve remission. But probably you are treating a SIT subtype or a SERD subtype, the challenges are different. The other thing we need to understand, even though we keep clustering in a background, probably I'm treating somebody who is thyroid subtype. This person may not tolerate metformin dose. Higher metformin dose, he may have intolerance. SGLT2 inhibitors, probably he may say he has some genital infections. So you need to think what is plan B, what are the other therapies you can use, and also you need to think of these therapies. So having a base of clustering definitely helps in managing your diabetes in our population. The other biggest challenge whenever we talk is the insulin therapy, and any insulin in our setup is considered like a death sentence. Probably you're at the last stage of diabetes, you have the misconception. People use the word called addiction to insulin. But they don't understand, especially if you talk about early insulin initiation, especially even in a newly detected type 2 diabetes. I think we have a lot of papers which have shown the importance of early and aggressive insulin therapy generally gives a better glycemic durability in the long run. But how many of us tend to do it? Probably an A1C more than 10, osmotic symptoms. Obviously, there is an inertia thinking we'll go with the conventional therapy. But again, various other factors also plays into role. Obviously, the infrastructure, the availability of the educator, nurse care teams, and all this. But generally, it is a barrier. Apart from insulin initiation, what is important is just by starting somebody on insulin doesn't guarantee a good glycemic control. The knowledge about dose adjustment, the type of insulin, the titration is extremely important. But the problem again with titration, you need to understand the importance of monitoring, whether it is an SMBG monitoring or a continuous glucose monitoring thing. This is a common thing which we come across in our practice. Generally, a person tells my average is always 7.5 to 8.5. I monitor my sugars. Every day my fasting is around 90, 94. But probably wouldn't have done his postprandial values. And obviously, when you say A1C is still 7.5, is your average wrong. And when you see him, same with the continuous glucose monitoring, you can see those beautiful mountains. There's nothing but your postprandial peaks thanks to your high carbohydrate intake. And that is obviously a weekday profile, and this is the weekend profile. And obviously, apart from just the HbA1c, it's very important, the monitoring and the AGP or the time and range metric is an important metric in our population, considering the high carbohydrate diet. And also we know that two people can have similar A1C, but obviously with a difference in glycemic variability. So it's important to know the limitations of looking at only HbA1c and treating. You need to consider the other factors in our people, especially people with brittle diabetes. So definitely, fasting PP, A1C may give you a long-term GV index, but time and range is also an extremely important. So if you're seeing somebody in a follow-up, just apart from fasting PP, A1C, either an SMBG data or an AGP data is extremely important to make those necessary adjustments. Otherwise, you may probably randomly do it for the name of titrating the dosage, but you will not be able to identify the fluctuations. The common challenge across India is the other important thing is the underrated thing is the diet. And we understand managing diet is all about reducing the white rice and changing to other cereals. But we need to understand across the board, our intake of carb is obviously on the higher side. The consumption of protein and healthy fat is much less. And even our response to carbohydrate is different compared to Asian Indians. We tend to have a higher glycemic response for the same glycemic load as compared to some of the other ethnic races. That's one of the reasons why we tend to have the agents like the alpha-glucosidase inhibitor. We tend to use more of premixed insulin or co-formulation, or just a basal insulin may not be enough because we tend to spike. The postprandial glucose plays a big contribution in our population apart from just the fasting blood glucose. Last but not the least is the psychological aspects in our treatment, the mental health. Because when you're treating somebody, you may talk about all the science and therapies and the precision, but what is often ignored is the mental aspect. The person whom you're treating, obviously the concept of the knowledge about the condition, his personality traits, his the health beliefs, all this definitely plays a very important role in determining the overall control as well as the follow-up. So mental health is something which is very important to address in our people. It's not just about the drugs, exercise, and diet. Mental health is a very important topic which has to be taken in every population, nothing to do with our population. But the point is, we have multiple health beliefs and alternative therapies which we need to kind of imbibe. So to summarize, diabetes is a significant health priority in India due to its large population and ongoing socio-economic transition. Challenges are complex and diverse in our country. Balancing both patient-centric care with precision diabetes care is the need of the hour. A multifaceted approach involving healthcare providers, policymakers, patient support organization, and appropriate use of technology, which is the driving force nowadays, can definitely help in delivering the standard of care and at least overcome some of the challenges. Thank you.